I'd like to start us off by asking each of our speakers to give us sort of the headline of their content. What's the latest, greatest, newest things that people need to know before we jump into the details? So, Jesse, maybe we'll start with you.
I guess what I'll be focusing today talking about, and we can talk about all aspects of diabetes, are some of the newer medications. And I think we've probably all heard in the news, and there's lots of discussion about some of these newer medicines, and I'm happy to talk about how they work and their effectiveness and who they're maybe best served for, and talk about some of the other treatments that are on the horizon, as well as issues of lifestyle, whether it's dietary treatments and exercise and things like that, about how to manage diabetes, because it takes all of these things. Yeah.
Great, thank you. Sara.
Sure.
For myself, I'm going to talk about things that aren't semaglutide for treatment. And also, I think if I had to convey one message today, it actually wouldn't be about diabetes. It would actually be a little bit about the Hospital Foundation, the Hospital Auxiliary, and while we're here, like as people that work at the hospital, we actually don't have a lot of opportunities to directly thank the foundation and the auxiliary. I mean, just today, I saw somebody who also works in the thrift store, and we were in a room, and I said, you just, wherever your eye sits is a piece of equipment that was provided either by the foundation or the auxiliary. So if you walk down the hall, if you're in a room and you see a blood pressure cuff, you see a stretcher, you see a chair, you see a piece of art on the wall, the foundation or the auxiliary had a play in that. So it's actually really nice to be here to talk about diabetes, which is so important to our community, but also to recognize all the great work that the foundation and the auxiliary do on our behalf to help Sechelt Hospital running. So thank you.
Thank you for that plug. And Lauren.
Yes, I'll be mostly addressing how we can take different strategies that you might be applying throughout the year, but specifically in higher stress or different contexts around the holiday period. So taking what you might practice if you're diagnosed with diabetes, but in those changing contexts around the holidays.
Okay, great. Sara, can we start with you? Has diabetes fundamentally changed?
So in the old days, we really had insulin, metformin, a drug called glyburide, and a class of drugs we don't even use anymore called thioglutamines. And now, when you meet somebody with diabetes and they need to be on pharmacologic therapy, maybe it'd be fantastic if everybody could control their diabetes with diet and exercise and weight loss, but there are many people who are going to need the help of medications. So now we've got the old, metformin still, we've got glyburide still, we have drugs like Ozempic, that's its own class of drugs called GLP-1 inhibitors, terrible name, I know. Another class called SGLT2 inhibitors, we can talk more about those later. We didn't even have, and we still have insulin. So, and then we have a class of drugs we don't use that much called DPP-4 inhibitors. So we actually have like 6 classes of drugs. It allows you to tailor therapy more to the individual. And the reason why these newer drugs have come to the forefront is because of advantages that they have. So the biggest difference is that we've got more tools in the toolbox, and these tools are actually better tools than what we had a few decades ago. And especially in the last couple of years, drugs that were previously not funded are now being funded, which is fantastic. So better funding, better options.
So Sara, has it changed though in terms of prevalence? I had heard somewhere that more and more younger people are presenting with type 2, type 1 being a separate conversation.
Yeah, for people that are actually you're right when you said about a third if you include people who have pre-diabetes, but for diabetes, the stats I've seen in Canada is 15%, but those numbers have actually gone up when even just compared to 5 years ago, and there's reasons to fear that that will continue to be a problem for our society, and part of that is weight and exercise patterns. Yeah.
So when we talk about risk factors, things to be aware of, indicators, what should people know that they don't already know? And again, given that so many people in this audience have some familiarity, what are the risk factors?
Yeah, we can't choose your parents. So some people are they're predisposed genetically. Some ethnicities have a higher risk. If you struggle with your weight, you're statistically more likely to develop diabetes. The exercise is protective. And then for symptoms, I appreciate that I'm speaking to an educated audience, but actually one of the most common ways that diabetes is diagnosed is you had a blood test done and it was abnormal. And that might have been done because you had screening blood tests, or it might be that because you had blood tests for whatever reason and your sugar was checked as well. So that's probably the most common reason. But sometimes people do present because they have symptoms. So that could be things like feeling tired, noticing that your vision is blurred, noticing that you're peeing more and therefore you're drinking more. Those would be the most common ways. And sometimes we actually have people who present to hospital with diabetic emergencies, and in hindsight they'd had these non-specific symptoms that have been going on for a long time, and then it's all kind of come to a head. But I'd say the most common way people present actually is that they had a test and they were found to have it. Yeah.
Could I ask a question?
Okay. The question is, do we see more diabetes because of increased sugar consumption? And I'm going to ask the dietitian that question.
Yeah, hand it off.
Well, certainly with type 2 diabetes, insulin resistance plays a role to that. And if you have kind of repeated exposure to very high blood sugar, that can contribute to insulin resistance over time. So certainly the quality of your diet may contribute, but there are also a lot of other factors. So often I will see people who have a narrative that either has been told to them or they tell to themselves that I did this to myself. I'm responsible 100% for this diagnosis. A lot of guilt and a lot of shame tied up in that. And to that I would say there are so many different factors that we cannot just look at the quality of someone's diet for a limited period of time over their entire lifespan and say, this is causal related to this. I hope that answers your question. It could contribute to developing diabetes, but certainly I wouldn't say is the only causal relationship there.
Do you think that there's also a difference in portions? What's provided if you go out now compared to what would have been on your plate 20 years ago if you went to a restaurant?
Yeah, absolutely. That is certainly a factor that has changed. The types of foods we're eating, the availability of those foods, like how often people are eating out or eating higher sugar foods than they were 25 years ago. Absolutely, those all contribute. And there are still ways to enjoy all of the foods that you might like, even if they're higher sugar foods, or to enjoy going out to eat. Shouldn't mean that those are off limits to you looking forward to your entire lifespan, but certainly trends have changed quite a bit.
Sarah, can we go back to testing for a bit? I know a lot of people monitor their own lab tests through eCompass, that sort of thing. So what should people know? What's the difference between a fasting glucose result and an HbA1c result?
All right. So if you don't have diabetes, your blood sugar usually hovers around 5. And if you have a fasting blood sugar and it's greater than 7, that meets the criteria for diabetes. And if you have a random sugar, you do a sugar at any time, you just had a meal, 11.1. So separate to that, there's a test that can be done called the hemoglobin A1c. And basically that takes advantage of the fact that hemoglobin, which is a protein that carries around oxygen, will become glycosylated, so it can be saturated, if you like, with sugar. And it's a way of, because of the lifespan of red blood cells, it's a way of actually extrapolating information of what's your blood sugar been like, not yesterday, not last week, but over the last 3 months. So it's a really helpful test. And if you did, someone who didn't have diabetes, the reading would be, say, 6. And when you live with diabetes, your target hemoglobin A1C just really depends on who you are. So if you are a young type 1 diabetic, you'd ideally like to see that level certainly like less than 7. I mean, the 6s would be great. And on the other end of the spectrum, if you were a person that was in a nursing home, who had many comorbidities, and sadly who had a shortened life expectancy, then you'd actually be satisfied even if that number was 8 or 8.5. And for a lot of people who live with diabetes and they have other health issues, maybe you're a person who's lived with diabetes, you're a senior citizen, and you have heart disease, actually we now would say 7.5 is probably reasonable. So the target really is more individualized than it used to be. And that's because of who incurs the most benefit, and also the fact that while we want people to have well-controlled sugars, we really want to avoid people having low blood sugars.
Can we talk then about the role of diet and exercise, because there's so many different types of ways to eat and exercises to do, and you hear about, you know, you have to have resistance training or you have to do this. I heard a podcast just the other day where they said, you know, anything you're doing that's extra to what you're doing now is a great start. So talk a little bit, and maybe all of you can jump on that one. How do you see the role of diet and exercise and how it fits into people's lives?
I think it's probably important to understand how diabetes, what happens and why does it happen in the first place. And it is a combination of what you're saying of sort of two different things. Either the pancreas, which is the organ right here in the middle that is making insulin, among other things, perhaps not making enough insulin. And you have what we're not talking about today, which is type 1 diabetes, which is when the pancreas just doesn't make any at all. That person needs to be on insulin throughout the day to deal with their blood sugar. So in type 2 diabetes, it's really a combination of the pancreas not making quite enough insulin that one needs, as well as the insulin that someone's making just not being effective enough. And that's the insulin resistance part of it. So that you have insulin, but it's just not working well enough to lower your blood sugar. And so there's these two aspects that are working together. And one of the reasons that diabetes is not the same thing for everybody is that for each person, it's going to be a varying amount of one problem or another. Is it more that they're not making enough insulin, or is it more that the insulin that they're making is just not working well enough? So it's some sort of different ratio for everyone that we can't actually figure out, but that's why it isn't a one-size-fits-all approach. We really have to individualize these things and figure out what is the problem in that person. And then I guess getting back to the idea of diet and exercise, that's also it's a very individualized thing. I think what you were saying is any activity is good. There's no rules on what one should be doing, and what I generally tell people is what you really want to do is what you enjoy doing, because if this is something that you're going to tell yourself you're going to go to the gym and you're going to exercise for this amount of time, but you really don't want to, well, maybe it's going to last for a week or a month, but it's not going to last for the amount of time that you have diabetes, or that you're at risk for diabetes, which is generally your entire life. And so finding some sort of exercise routine that's enjoyable, that you find satisfying, and that is realistic, whether you have arthritis or whether you have some other limitations. It's really a matter of finding something that works. And it's not that everyone has to get out and do very vigorous exercise if they're not really capable of it. And it's really about getting your heart rate up as you can and being as active as is realistic.
A negative exercise trial.
Right.
So if people go out and they walk for 30 minutes every day, every study will always show that that's a benefit. So I totally agree with what you say. If we told everybody, thou must swim, well, I wouldn't be able to do that. So some people are going to want to walk, some people are going to want to go to the gym, some people are runners, some people like to play sport. I'm so delighted when anybody makes a lifestyle change that involves exercise. Fantastic. And I think with diet, well, Lauren's obviously the expert here, but I feel like it's a bit of the same in that if we told everybody, a vegan diet is really good for the planet, everybody should be a vegan, that would actually be really hard for everybody to accomplish. And on the other hand, if someone told me I had to be on a carnivore diet, it would be terrible for me because some of what we choose for our diet is preference and our digestive health. Maybe you want to speak more to that though.
Yep, absolutely, 100%. And I think so much, it's very on topic today, given that we're talking about the holidays as well. But a lot of what influences our diet is cultural. So how you were raised, the holidays that you engage with, how you socialize with people. So absolutely, in the same way that we've just heard, exercise is not one size fits all. Diet isn't either. I think diet is very important, and very important to how you manage your blood sugars and your health goals in regards to managing your diabetes, but certainly can be tailored to the individual in many different ways. So it doesn't have to be and shouldn't be really highly restrictive or something that causes a lot of anxiety or stress for the individual. It should be something that is realistic. And same with I would echo everything that was said about exercise as well. There's a term that I really love that's called, instead of calling it exercise, I've heard in a lot of spaces it being referred to as joyful movement, which I think is awesome. I don't know if it makes me get up any earlier when it's cold outside to get my joyful movement in, but certainly I think reframing how we anticipate these interventions or how we regard these interventions can be a really big piece in the repetition and the habit building of it all. So going in with the understanding that this is something you're supposed to be enjoying, and it's supposed to be, whether it's line dancing, I saw the Healthy Hearts program has some info on that, or chair yoga if your mobility is limited to a seated exercise, or if it's, going for that 30-minute walk after a meal that might help manage your blood sugars immediately, that sort of thing. Yeah, absolutely. Keep it joyful.
That is the same thing with exercise, is that you want it to be something that is sustainable, something that you're going to be able to keep up rather than just being a temporary change to diet. And the other thing is that it's also not a one-size-fits-all thing, both for all the reasons that were said, but also because different foods affect different diabetics differently. And so one person could have a piece of toast and their blood sugar is very high, and for another person it has no effect at all. And so that's where some of the testing comes in, where we're checking blood sugars and we're trying to figure out what is it for that individual that is easier on their blood sugars and what isn't. And so that's another way that things are different between different people living with diabetes.
Can people tell within themselves if their blood sugar is spiking? And the answer to that is often you can't. So because a variation, like say your blood sugar was 6 and it went up to 10, often you're not going to notice a change in how you feel. So when it comes to how foods affect an individual, I think for a lot of people who live with diabetes, it's trial and error.
This is like a 2-hour consultation with your doctor, which you'll never get, by the way. This might be a contentious question. Can you reverse type 2 diabetes, or at least get off medication strictly through diet and exercise?
Maybe I'm happy to start. There's fairly good evidence that it is possible, but it's only possible sometimes. And I think one way that's highlighted is there's studies that say with people who are quite overweight or obese and have undergone things like bariatric surgery. So they've had surgery for weight loss, they've lost a lot of weight. In many instances, their diabetes can be either significantly improved such that they don't require any medications, or potentially even reversed. I think would be an open question to say whether someone's diabetes is gone, or maybe there's other terms we could use, that they're probably always at risk, because the likelihood is if that they regain the weight that their diabetes is going to come back. And in other people, you can see that they were able to make significant changes to their diet or lose a lot of weight, and we do see significant improvements. But that's not everybody. And so in some instances we'll see that, and I think it's probably fair to say that it's the minority of patients with diabetes where that type of reversal with diet and exercise is possible.
Sad is that time is against you, so you're more likely to become diabetic with each decade of life. So right. That's why you can start out being on one drug, and despite your best efforts, maybe later in life you're on 2 or 3 drugs. But absolutely, I've seen folks that have made great dietary changes and have been able to reduce or stop all medications. Sometimes you can pick these folks out from the crowd. Like I've seen a few people who come in, they didn't know they were diabetics, but it turned out they would drink like 2 liters of pop per day. That's a great one. That's a pretty easy fix. That person just making a fairly simple dietary change is going to make a massive difference. But a lot of times we see people who have diabetes, it's not the case. Yeah.
Do you find patients come in and say to you, I don't want to take medication anymore, what can I do?
No.
Okay.
Well, there's definitely people will say that, or especially at the onset of their diabetes, I get fairly often, well, maybe I can do this without medicine. And so sometimes it works, but I think one of the problems is that we'll often go another month, another 3 months, and there's this sense, well, okay, it didn't work this time, let me do it again. And this feeling like that each time they make these big efforts and changes, that then they're failing. And I think that's the hard part, is that we really need to see this not as just as a lifestyle disease, but as a real disease that can't just be reversed with good intentions.
We have what's called referral bias. So we see people that have been referred for management of diabetes. So that's a different kettle of fish than someone who has newly diagnosed diabetes and is really trying to avoid medications. Usually we see folks because they're having troubles managing their diabetes and they're already on medications. So I shouldn't have been so flippant, because I wasn't trying to say that people don't want to change their lifestyle. It's just that usually when we see people, their diabetes is very well established. Yeah.
And I think I'll just add to that also in terms of what we were talking about before, the reason for diabetes is and how it changes over time is that with time, and the longer you have the disease, the less insulin you start producing, and then the harder it is to control over time. And so what may have worked at the beginning may not work so well as you go on.
Right. So let's talk about the traditional medications and the pros and cons of those.
So if you are a newly diagnosed diabetic, the first thing is always to see what you can do lifestyle-wise. So I do encourage people to use the Dial a Dietitian service or see a dietitian, or to educate themselves, like go to the Canadian Diabetes website. It's actually quite good. The library has a diabetic cookbook. So I think that's important. Talking about exercise is important, but many people are going to need to be on medications. And then what medication you pick, it's really a few factors you have to think about. So you have to think about the patient, do they have any comorbidities? Because some medications actually give you a 2-for-1 benefit. So if you live with heart disease or you live with kidney disease, there's some medications that actually will help both problems. If you're a person who has diabetes and you also struggle with weight, then maybe the drugs that Jesse's going to talk about would be a good fit for you. Then there's like the practicalities. Some medications are actually really expensive. So luckily all classes of medications are covered by pharmacare. Some only with special authority approval, which just means that you have to fill out a form. But if I prescribe a medication to you and it's covered by pharmacare, but everybody has to pay their deductible. Some people are really surprised by that. Your deductible might be $2,000. So if I prescribe a medication that's going to cost you $200 per month, and you don't have extended health, you're going to be paying that every month until you reach your deductible, and you can't afford it, I haven't done a good job treating you. And then the other factor might be severity of disease. So not all medications are created equal. So if you are a person whose hemoglobin A1C, if it's 7, you have diabetes, say your hemoglobin A1C is 10, that happens all the time, then we're going to need to choose more potent medications, if you like. For practical reasons, the backbone of diabetic therapy for type 2 diabetes and all this remains an old-fashioned drug called metformin, which has been around for decades and decades and decades. I think it's about 50 years old. Super cheap, pennies a pill, covered, does not cause lows, which is great. It's weight neutral. If you have very severe very severe kidney disease or very severe liver disease, it's not the drug for you, but you can use it in almost everybody, and the coverage of other drugs is dependent upon that drug being present. So you can only have drugs like the one Jesse's going to talk about, semaglutide, covered if you're on metformin, or there's a reason that you can't be on it. So metformin's sort of it's like your base level car. Yeah, because it works and it's cheap and it's covered. Another drug that's on the shelf still is called glyburide. That drug works in a completely different way. It basically causes your pancreas to release more insulin. And because of that, it has some side effects that nobody likes. So it is a drug that can cause lows, and it is a drug that causes weight gain. So for those two reasons, it's less used now than it was 5 or 10 years ago, because we have other tools in the toolbox that we didn't used to have. It still has a place. It has some advantages in that it's a pill and it's very cheap and it's covered. Okay? I feel like that's a lot of information already. There's definitely people in the audience. A drug called empagliflozin or dapagliflozin. These are SGLT2 inhibitors, a newer class of drugs that's been available for about 15 years, works in a completely different way. The way to remember these drugs is I call them the sweet pea drugs. So they cause you to pee sugar. That's how they work. It's like your body is a cup. And if your sugar level goes above the rim of the cup, you will spill it into your urine. Okay? Because of that, it cannot cause lows. It's only going to be working if your blood sugar is high. Great advantage. It causes a little bit of weight loss in the order of 1 kilogram or 2. It doesn't cause weight gain because it's a little bit of weight loss. Because of the way it works, it lowers your blood pressure a little bit. It's also been shown to be protective for people who have kidney disease. So there's actually a lot of people in our community who have kidney disease who do not have diabetes who are on this that class of medication. And it's been shown to improve survival and hospitalizations in people who have heart failure. So it's also used in people who have certain types of heart problems that don't have diabetes. And what's the catch? The catch is the cost. It's about $200 per month, so it's really expensive. And because the way it works, it's causing you to pee out sugar. You can see what the problem is. The problem is going to be in yeast infections. We see this both in women and in men. So women can get yeast infections in the vagina, and men can get infections at the end of the penis. Nobody likes that. Small increased risk of urinary tract infections, but that increased risk is small. You can even get skin infections in the genitalia. That is the main problem with that class of drugs. And because of the way they work, they're the sweet pea drugs. If you're somebody who already struggles with urinary frequency, maybe you're a female and you struggle with incontinence, you might not like a medication that's going to cause you to pee more often. So there's some practical reasons why it's not for everybody, but it's a really good option to have in the toolbox. And then I'll let Jesse talk about semaglutide and the last class of drugs that we don't use a lot of. So I think I'll save that if there's any questions.
Yes, we'll save that one because we want to have Lauren talk us through healthy eating ideas. And the thing about nutrition, I think you would agree with this, is that the advice has been changing over the years. In the same way that the amount of alcohol that is allowed has also been changing over the years. So there's some new thinking. So maybe, Lauren, if you could give us an idea of what's the most current thinking about a healthy way to eat, not just for type 2 diabetes, but for everybody.
Yeah, for
and
sure.
And you do have things up on this,
yes,
which
excellent.
are available.
So certainly I would say, like right off the top of my head, I think the way that we communicate to people, and when I say we, I mean like the dietetic profession, how we communicate to people, how we're liberalizing or relaxing a few of those really stringent nutrition rules. We're really moving away from that language because it's very difficult to apply very strict rules to your day-to-day when we anticipate something like diabetes or any other health care condition that's chronic is going to be something that someone might live with for the rest of their lives. So certainly the direction that advice and that the information is moving to is something that's more approachable and more flexible and more able for you to take and apply to your regular behaviors, whether that be foods you enjoy cooking, foods you enjoy eating, foods you enjoy sharing with your family members. I would also say that we're moving away from a very prescriptive, you must have this many portions, you must have this every day, towards more of a, if we can get, oh, excellent. The plate is up on the screen, which is excellent. This is like what we call the plate method for managing blood sugars. And if you pass the tables out at the front, you probably also saw the tearaway packs of Canada's new food guide. So maybe when you were coming up, when I was coming up, the food guide was a rainbow, and it did say you have to have 4 to 5 portions of this, 2 to 3 of this. Some people, they experienced the food guide as a pyramid. For other people, it was other shapes, but it was always very prescriptive. This, I think, is much, much better, much easier to apply for people on a daily basis, and much easier for people to apply to individual meals. So something like this can really be helpful for guiding not only your everyday, but say you're going to a holiday party, or you're going to a family gathering, or even if you're going to a restaurant out to eat, using this kind of breakdown of trying to aim for your consumption at that meal as 50% fruit or vegetables, with more of the emphasis on vegetable intake, 25% on your protein, and 25% on your starch, can be really helpful for managing your blood sugars for a couple of reasons. Not only because in the typical Canadian diet, I would say protein is a big star of the show, as is carbohydrate, and then sometimes maybe there's a sad pile of broccoli that gets scraped into the trash at the end. Hopefully, we've kind of come around to finding different veggies that you might enjoy eating, and that would take more of a star on the plate. So controlling the portion of that carbohydrate, which will influence your blood sugars after a meal, is only one way that this really works. It also really works in providing a lot of extra dietary fiber on the plate. And we chronically undereat fiber kind of as a culture, as a country, and making sure you have an adequate amount of things that are growing, so your produce, can really be helpful in providing you with that extra fiber. And one of the roles that fiber plays, in addition to all of the gut health benefits that we're still learning about, is that it slows down digestion. So when you're having a meal that does include some carb, like if we're thinking about holiday meals and you know there's going to be sweet potatoes on your plate, or there might be mashed potatoes or a dinner roll, or any of the other carbohydrate foods you might enjoy, if you're having that with something that is higher fiber, so you're choosing a whole grain option of that carb, or you're choosing to add some extra fiber in terms of the veggies on your plate, we're going to slow down how quickly that digestion is. And so instead of seeing that big spike of blood sugar, you'll still have the same amount of carb, but it'll digest more slowly over time, so we avoid those big highs that push up your A1C, if that makes sense. So this can be really an excellent way to apply to specific meals, and then also to apply to, how your day is going, your overall dietary pattern. If you know, oh hey, I hit some starch and some fruit this morning, maybe it's time for a snack where I focus more on the protein side of the plate, or I grab something that's more veggie-centric, that sort of thing.
So Lauren, I see we have a glass of water, and it's Christmas time, and everybody's going to invite you to come over and get together for a glass of water. Not. Are there specific considerations for people with type 2 diabetes around alcohol?
Yeah, I think thinking about beverages in general, if you are taking in specific insulin or some of those medications that Dr. Wadge mentioned that increase your risk of a low blood sugar, really important to know how the consumption of alcohol might affect that, which typically consumption of alcohol, like wine and spirits, will bring you at risk for a low blood sugar if you are using insulin or some of those medications that put you at risk for a low. The other medication groups, or if you're managing type 2 diabetes just with lifestyle, diet, and exercise interventions, you will have no risk of a low, or very, very little risk of a low, especially if you're having alcohol. I think being mindful of what we might be mixing with that alcohol is really important. So if you were having like a rum and coke, for example, and you're not taking insulin or those types of drugs that increase your risk of a low, I'm not so concerned about the rum, but I might be more concerned about the coke on that side of things. And when I say concerned, I just mean mindful. So certainly you can include these things in your holiday rituals for sure, because it's a special time of year and your patterns might be a little different than they usually are. But I would encourage you to maybe choose options that will have a lesser amount of sugar added, or the no sugar options. So there are lots of different beverages you might experiment with to make a mocktail, for example. Like, I'm sure we've all heard of like the bubbly, or tasted them or seen them. Those flavored waters that have no sugar added are excellent, with a twist of lime or lemon. Or we can be reaching for diet sodas, or sodas and drinks made with non-nutritive sweeteners, which are non-nutritive sweeteners are basically none of our sugars. So could be like our Splendas or our Stevias, or other sugar alternatives, that sort of thing. And also just being mindful of other beverages too. So it's not only the alcohol that we might be looking at, but could also be things like hot chocolate or eggnog, or a hot cider. All of those are going to contribute a pretty significant amount of carb to your meal. So if we're planning ahead and we're strategizing a little bit, and oh hey, it's a family tradition that we all sit around and have a glass of eggnog, then I would say enjoy that tradition, but plan ahead for it. So maybe when you're filling your plate, you're a little more modest on the carb that you're taking on your plate. Or when we're thinking about dessert, you consider the eggnog part of your dessert. Or being really important, keeping that sugary drink close to a meal that does have lots of fiber, like I mentioned, and a good source of protein, so that we know, because drinks metabolize so quickly, a sugary drink will really send you high. But if you have that alongside a meal, again, we can temper the effect that has on your blood sugars for sure.
Great. You also have a couple of recipes that you wanted to quickly flash up.
Yeah, absolutely.
Sort of alternative ways of doing traditional things.
Definitely. These are just a couple of options, if we can get the slides up. Yeah.
Just a second. There's one.
Options. It should be mentioned that around the holiday, if you're invited out places, or if you're going to a restaurant, we might not always have control over the menu. But if you are in a situation where you can contribute, like a potluck style, or everyone in the family is bringing a dish, certainly choosing items that will help you stick to more of that plate method it's a really smart option to do. So there's a couple of recipes that I pulled, not because they're in particular the most fabulous recipes, but they're from the American Diabetes Association, which is a great resource, and I just wanted to shout them out because they've got so many excellent resources. There was one for, this mashed potato, which is actually a combination of mashed cauliflower and potato, which is great because you're boosting the fiber there and controlling the carb. And then there's also, I believe before, there was a salad that had lots of apple and lettuce and lots of higher fiber options, again, to kind of fill out that half of your plate. They also have really good dessert options, which I don't think we have a slide for that, but I was looking at a pumpkin pie recipe they have, and absolutely, I want to make it known that dessert is okay. It shouldn't be something that's totally gone from your vocabulary. Again, it's something that we strategize for, that we think ahead about, and if we know we're including that in our meal, maybe we think about how much carb we're taking on the main plate, and maybe we're the ones to bring dessert, and we bring a dessert that helps to support your blood sugars, and that it might have a lower amount of sugar, or might be using one of those sugar replacements like Splenda or Stevia, like I mentioned before. And again, really great resource. The Diabetes Canada, as you mentioned before, and the American Diabetes Association, Diabetes UK, they all have really excellent resources, as well as Dr. Wadge mentioned, the public library is an awesome resource for those cookbooks.
Okay, thank you. Jesse, can we, how many people here, can you write that question down and then give it to us after, okay? How many how many people here are on Ozempic or are interested in Ozempic? Okay, so let's talk about the new kid on the block.
Okay, all right. So maybe it's helpful just to understand firstly how these medicines work. And it's not just Ozempic, which is called semaglutide. There are other similar medications, and they're not really that new. In fact, we've been using them for about a decade. But these things get better over time. There's more studies. They're manipulated a little bit, so we see improvements. But they're not really new, and in fact, these have been under investigations for many decades. But it is helpful to understand a little bit how the medicines work in the first place. And so there's a natural system we have in our body that controls our blood sugar and controls our appetite. And so these medications take advantage of that system. And GLP-1 is the name of a hormone, and it's a hormone that is produced in the gut, in the intestine, and is released from the intestine after eating. And it does a whole bunch of things, but there's really two important things that are important for diabetes or for blood sugar management and for weight management. So one of the things it does is it's released when your blood sugar is higher after eating. And so it travels from the intestine to the pancreas, and it gets your pancreas to make more insulin. And so it's not just making more insulin all the time, such as a medication like glyburide or like insulin, but it's raising your insulin levels when you really need it. And so this is just your own hormone, not talking about the medication yet. This is how it works. The other thing it does is it acts on receptors in your brain and in your stomach, and it tells us that we're full. Because as you can imagine, if we just kept eating and eating and eating and didn't stop, well, that would be a big problem. And so this is one of the signals, and there are other signals, but it's one of the signals to our brains that we've eaten and we can stop now. And so the scientists that have worked on this have figured out that they can manipulate this system to increase the levels of this GLP-1 so that we're making more insulin in response to food, and that it augments that sensation that we're done, that we're full. And so on the one hand, this helps with controlling blood sugar and improving diabetes. And on the other hand, it helps with weight management and leads to weight loss. And that then cycles back in to improve diabetes, because when we lose weight, then there's less insulin resistance and our insulin is more effective, and that then improves improves diabetes. So that's the basics of how the medications work. There are countless research studies on these, and there's lots that are going on, and we're learning, and there's newer and newer medications. So one of the reasons that we talk mostly about Ozempic here is partly because that's the one that the Pharmacare program has chosen to cover. There are others, but there's very good evidence for semaglutide. And so this is a study showing the use of semaglutide in someone with diabetes or in people with diabetes that aren't on anything else. So this study here just shows the effect of the medication as the first medicine. And what it's showing is that there is a very significant reduction in this A1C compared to someone who's on placebo who is on a sugar pill. And we can see this is with the two different doses. There's the 0.5 milligram and the 1 milligram dose. They're given once weekly by an injection. And you can see up to significant reductions of about 1.5. And that is quite a major improvement in someone's diabetes, and tends to be more pronounced, more effective than most other medicines we have. So this is just one of the earlier studies showing that the medicine really, really works to improve someone's diabetes. So not only does it it has improved diabetes when you just take it as its own medicine, but it also improves things when you take it in addition to other medications. And so various different studies have shown that when added to other medicines, and even when added to insulin, it can be very effective. And so this one we're looking at is a study that showed that sometimes people are on insulin, what's called long-acting insulin. So they take an insulin that's in their body all day. And this was a study that looked at whether it's better to add semaglutide or Ozempic to that, or whether it's better to add insulin, extra insulin that people get with each meal on top of the long-acting insulin. Sometimes when diabetes is very difficult to control, we have to give insulin with each meal in addition. And so what this study showed was that the semaglutide was actually better than that extra insulin in terms of improving diabetic control, or A1C. But on the bottom, you can also see that it improved someone's weight significantly rather than the insulin side where they gained weight. So there was a significant increase in weight with insulin and a decrease in weight with this medication, semaglutide. So these two studies are just highlighting that the medicine works, that it's very effective, and that it can be used in various different situations in combination with other medications.
So given that you have all said that obesity is a huge risk factor, then addressing that through Ozempic, I know you're a fan, so I think you do have one more slide about that. Sarah? Yeah, there we go. Here's your big slide.
Well, I don't want to say, like you said, a fan. Medicines aren't, we don't just want to prescribe medications, but it is, we do want to make people feel better. We want to improve their blood sugars, but we also want to reduce complications. And so one of the things we haven't talked much about today is that diabetes isn't just about improving numbers. It's about preventing blindness. It's about preventing amputations. It's about preventing kidney disease and preventing cardiovascular disease. So we like these things not because we like to see nice numbers or we like to prescribe medicines. We like these things because they make people better and they prevent complications. And so these medicines are now, as we all know, are being used not just for people with diabetes, but for people with obesity, who are having weight challenges, who haven't been able to lose weight with other means. And what we're seeing is a very significant reduction in their weight, and that reduction lasts for a long time, as long as they're taking the medication. And so on average, people will lose about 15% of their body weight, which is quite significant and certainly better than any of the other weight loss medicines that have ever existed in the past, and are better than most of the studies that would just show that are with diet or exercise alone. And so that's what this slide shows. This is just a study of people with obesity who are either just following a diet and exercise program or are following that program in addition to this medication, and we see the significant reduction. One thing to keep in mind, though, is if you stop the medicine, the weight goes back up. And so this isn't a temporary thing to improve someone's body weight and then they can stop it because they got to a different place. It probably doesn't work that way. It's causing a reduction in appetite, and the body probably has a set point where it wants to be, and as soon as we stop the medicine, most people go back up to what that set point was.
Can we talk about glucometers, glucose monitoring?
Sure.
Whoever wants to
talk,
jump on that
I'll
one.
take a break.
There's a lot of questions about continuous glucometers. They're fantastic. I mean, they're really quite nice. I mean, you have a device, it's connected to your smartphone. At any time, you can see what your blood sugar is. And this can be a way of getting immediate information about how a certain your mood does affect your blood sugars. Meal can affect your glucose. You just get immediate information. Actually, Jesse did a nice talk for our medical group, and he volunteered to wear 2 different models of continuous glucometers for a few weeks each, and then he could sort of tell us like the ins and outs of both, which one was more comfortable, and I mean, that's all a bit of personal preference. But I also really enjoyed his stories about how Jesse doesn't live with diabetes, but how he had a specific type of cookie, and then he was like, "What's that noise?" And it was his glucometer going beep 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 beep. He immediately realizes that that type of cookie doesn't suit his body. And you also hear people who have stories where something's happened that's affected them emotionally, and they'll be able to get that information about how their emotions affect their blood sugars. So they're fantastic. So you think, oh, what's the downside? Well, the downside is the ongoing cost of changing the, would you say it, the sensor. So depending on which one you choose, like the Freestyle Libre is about $200 per month, so that's pretty expensive, and the Dexcom is $400 per month, pretty pricey. So the Pharmacare will cover the more expensive one, actually. That's the one they cover, but it's very narrow. So basically you have to be a type 1 diabetic or a type 2 diabetic, but you have to be having real problems with lows, right, Jesse? Which we don't really see a lot of. So most people who use this, they either can pay for it privately or they have extended health coverage, but a lot of times the extended health coverers won't pay for it if it's not covered by Pharmacare. So if you have extended health coverage, it might cover the cost until you reach your deductible, but most extended health care providers are not covering the cost. So I think what will happen is with time, the cost of these continuous glucometers is bound to go down. It'll just get cheaper, and I think more and more people will choose to use it because most people have a smartphone. As long as you can turn on a smartphone, and they're actually really easy. So the biggest barrier to their use is actually the monthly cost. But they're great. If you buy a glucometer, it's really cheap. And actually, you could speak about strips, but doing occasional checks is a great idea. Depending on what medications you're on, that sort of determines how often you need to do a check. So not everybody needs to do checks every day. There's a minority of people who need to do multiple checks per day. So we try to treat people like the individuals they are. But the old-fashioned glucometers, they work, they're cheap. Yeah.
So I have one more question before we start collecting the written question forms from the audience, and that is, I hear Alzheimer's disease being referred to as type 3 diabetes.
Oh.
Why?
No idea.
What is that about?
I think you'd have to give a little bit more information where you're hearing that from.
I was seeing some
that
brain scans that were showing the impact, I guess, of maybe it's insulin resistance.
Well, I
or
think there's definitely a
something.
link between diabetes and the onset of dementia. I don't know Alzheimer's in particular, but I don't know, I can't speak to exactly how clear that link is.
It's absolutely known that if you are someone who lives with Alzheimer's disease and you have the misfortune to have vascular disease on top of it, meaning you've got problems in the blood supply to your head, perhaps you've had strokes or mini strokes, you're more likely to have worse progression of your disease. But I've actually not heard that term. I'll have to look that up.
Okay, I'll send you the references that I found it in. So listen, having information is just so important, and I think that's why we love doing these med talks, because the more you know, the better equipped you are to ask the right questions when you see your doctor, and the better equipped you are to take some of the measures that we've talked about in terms of food and medication. So I believe it's time for us to collect the questions from the audience, but while we do that, I'd like to thank you all so much for doing it. As I say, it's like the longest doctor's appointment where you can ask all these questions that you never get a chance to do otherwise. So thank you so much. Okay. And Jane will have these questions, so I will let her curate those up here on the stage.
Maybe I can ask a question. The only patients I saw with diabetes in my career was patients with gestational diabetes. And obviously, once you diagnose them, you try and guide them through pregnancy and deliver a safe baby. But once that has happened, I never see them again. So can you give us some idea about what happens to them in their lives later on, and what are the risks for diabetes later in life?
Most of the time, for most women, their diabetes will resolve once they deliver, and then they tend to be more at increased risk for developing type 2 diabetes down the line. So it is important that they have more frequent monitoring and to see if they end up developing type 2 diabetes, have more frequent screening.
I have a couple already, early submissions, thank you. In the presentation discussions today, there was a mention of diabetes leading to amputations, and that sort of made the crowd go ooh. And there's also a question here about neuropathy, and is it reversible, and how are the two connected, or does one lead to the other, and is this all part of diabetes? Tingling in the feet, it gets worse, especially when lying down or sleeping, and is Ozempic good for something like that?
The first question was about amputations. Well, obviously, most people who have diabetes are not going to have an amputation. Sure, most people who have diabetes obviously are not going to be at risk for amputations, but diabetes is a risk factor for developing hardening of the arteries or plaque, and one of the most common reasons that people have amputations is very poor circulation. So it is true that we can, by controlling diabetes, we can help prevent that complication. The other reason that people who live with diabetes can be at higher risk of amputations if they do have something like neuropathy and they end up with a foot ulcer and they have a wound that won't heal. So these complications, fortunately, are not that common. But if you looked at the number one risk factor for having them, it actually would be diabetes. But that's not to make everybody in the audience scared that that's going to happen to them. What we're trying to say is that diabetes, not something to think about as a lifestyle disease, it's actually a disease that has consequences for individuals. Sadly, peripheral neuropathy can get a bit better if you start out with really high blood sugars and your blood sugar is lower. But unfortunately, peripheral neuropathy is due to death of small nerves, and I'm sad to say that those nerves just don't grow back. It doesn't mean that you should feel nihilistic about it, because controlling your diabetes can actually help that problem from getting worse, and in some cases you can see some improvement in symptoms. But peripheral neuropathy, which is an unfortunate complication of diabetes, that's actually quite difficult to treat. So when people have that, they might feel burning in their feet, or stabbing pain in their feet, or numbness of their feet. It can be quite distressing for people. So I'm sorry to hear that there's somebody in the audience that has that.
Question. In the UK, they're recommending the fast 800 calories for up to 12 weeks. Are you familiar with this? Would you recommend it as a way to lose weight and reduce diabetes risk? Your thoughts on PGX, and how is fatty liver connected? If that's all one question, I'm not sure, but could you start with the idea of the fasting sort of regimen?
Sure, I'll tackle the fasting. Fasting is not something I routinely recommend, especially at an extreme caloric deficit to 800 calories. To put that in context, like when you're reading a nutrition label on the back of a food item in the grocery store, it is tailored towards, it's meant to be like what a average or general diet might be, and that's 2,000 calories. So we think of taking less than half of what the average person might need for calories and saying, I don't know what the weeks, it said for 8 weeks, subsist on this for 8 weeks. In the short term, you're going to experience lots of side effects to that. You're going to be feeling sluggish. You'll probably be feeling a little bit hangry, for lack of a better word, really upsetting, honestly. And it's not a long-term solution. So the way nutrition and dietetics is moving is towards longer-term solutions that are easily applied to the habits that people already have built, because we know habit building is and habit breaking is a really, really difficult part. That is not only, it's not really a question about willpower, as in you must be strong enough to make this
choice or change in your life as much as it is, you know, a product of the environment around you. So doing these really extreme measures, like again, when I was coming up, the cabbage soup diet was a big thing, where you only eat cabbage soup for like 6 weeks. Or there's the maple syrup diet, where it's maple syrup and cayenne pepper, and that was how they achieved this really extreme caloric restriction. If you had a very extreme caloric restriction, in that you would be really extremely restricting your carbohydrate intake. So of course your blood sugars are going to look lower for that abbreviated period of time. But we also have to be asking, when we're taking things off your plate, what else are we taking off? Are we taking off a source of protein, which is helping you maintain your muscle mass and promoting good mobility? Are we taking off sources of calcium, which are really important for bone health and again, mobility, especially in women, you know, post-menopause for sure? Are we taking off the fiber from your plate? You know, it's just, I get very concerned about what we're kind of foregoing with these really invasive and short-term solutions that we think might cure or reverse diabetes. And I wonder about the long-term evidence for an intervention like that, and what happens when you're done the 8 weeks on such a strict caloric intervention. Because I would assume that your dietary habits would go back to what they've been, you know, lifelong. That your carbohydrate intake would be very similar to what it was before this very strict dietary intervention. And so I would imagine that any benefit you might see in terms of your diabetes management would be very short-lived. And I wonder kind of what we're exchanging for that short-lived benefit. So I'm always thinking about outcomes. And this is a disease or chronic health state that we're managing in the long term. We're not thinking about days and weeks, I think. I don't know if that would be a good way to phrase it, but yeah, that's my take on that. So.
Fatty liver is just when your liver is marbled with fat. Obesity is a risk factor for both diabetes and fatty liver. And if you are a diabetic person, you are also seen to be extra predisposed to fatty liver. So one of the things we know that managing diabetes and managing weight, fatty liver is something that is reversible.
I think the mics are live, yes?
Testing. Yeah. Yeah, I'm not sure what the specific question was on fatty liver disease, but like Dr. Wadge said, it is connected to overweight and obesity, although in some patients we see it even with normal body weight. But the mainstay of treatment for that is regular exercise and gradual weight loss. And it can be reversible with changes in body weight. If that answers the question, I'm not really sure what it was.
These might be some follow-ups to that question.
Okay.
And you've talked a couple times about comorbidities, meaning multiple issues going on, correct? Is it important to have an oncologist when you are type 2? And then as well, can you speak a bit more about how diabetes interfaces with thyroid glands and the liver area? Just maybe a little bit of a 101 on how these things are all connected.
I guess the question about diabetes and oncology or cancer care, there isn't really going to be a direct link between these two things. And so just because you have diabetes doesn't mean that you're going to be any more at increased risk for cancer than anybody else. So it wouldn't be standard to need an oncologist just because of having diabetes. In terms of the thyroid, I mean, we're all connected. All of our organs are working together and we're all one system. The thyroid, someone who has an underactive thyroid may feel more sluggish and may have slower metabolism, and that can cause weight gain. But aside from that, there really isn't going to be a direct link between thyroid disease and diabetes, with the one issue being sometimes people have autoimmune diseases and can have perhaps type 1 diabetes being more at risk for thyroid disease. But otherwise, I don't think we're looking at significant links between these things.
Here's a question. So, Lauren, can you explain sort of the day in the life of the dietitian and how you work with the rest of the hospital, and how you are involved in patient care in the hospital and maybe even outside of the hospital?
Sure, yeah. So I divide my time 3 days a week. I'm at the hospital and I do inpatient and outpatient care, meaning I'm upstairs with the patients who are admitted, and that can be for various reasons. A lot are on therapeutic diets, like if a patient with diabetes was admitted to hospital, they would usually be on a diabetes diet, and sometimes I would follow up for different things associated with that. For outpatient care, I receive referrals from the family doctors here on the coast, or other specialists or even nurse practitioners will send referrals in, and I will have like appointments one-on-one with patients. And then 2 days a week, I'm out in community with home health care, and that's for patients who are non-ambulatory and generally not able to leave their homes, and so the care comes to them, and I'm part of the Lower Sunshine Coast home health care team. So it's very collaborative in all areas. So working with the nursing staff, working with pharmacy, OT, PT, of course the physicians at the hospital and in the community who are sending the referrals to home care. Yeah, it's one of the great things about working here is how it's all very team-based, which is great.
Here's a question. Some prominent U.S. physicians say that testing for blood sugar is not sufficient. They say that you need to test for insulin and insulin resistance with a test like HOMA-IR. Does that mean anything? What are your thoughts on the testing and the identification of diabetes?
I guess the question we have to ask ourselves when we're testing for different things is the test going to change how we manage the problem? So testing for diabetes is fairly straightforward, but doing more complicated tests to figure out the exact, perhaps the exact problem in that individual is unlikely going to change how we actually manage the diabetes for them. And we can figure out how best to manage an individual's diabetes based on their patterns of blood sugars and based on how they respond to various different treatments. So although there may come more tests and different tests that allow us to perhaps treat people differently at this point right now, I don't think those tests that tell us insulin levels, for instance, are really going to change how we manage the disease in the vast majority of people.
This is maybe a specific one, but hopefully reinforcing the role of a GP relationship. Does diabetic medicine, and I can't pronounce if it's Jardians, interfere with blood pressure medicine or vice versa?
You should.
So Jardiance is also called empagliflozin. That's one of those sweet pea drugs. It will lower your blood pressure a little bit. So sometimes, and people can lose a little bit of weight. So when a person starts on that medications, it's not uncommon to have to adjust their blood pressure medications. For instance, if you were on a water pill, that might need to be reduced. So yeah, drugs like empagliflozin can affect your blood pressure and can also affect what other medications you can be on.
Can you just remind the audience of some of the signs or the symptoms if you're feeling this, that, or the other, when people might not even know that they have diabetes? What are some signs to be looking for and reasons to go see your GP or your nurse practitioner?
So I think basically, first of all, everyone should have screening from time to time. And it's an important reason to see your family doctor and just have a very simple blood test. Because I think, as Dr. Wadge mentioned, most of the time we don't have symptoms unless the blood sugars are really quite high. And just to reiterate some of those symptoms of when the blood sugars are quite high, it can cause fatigue. Maybe it leads to a little bit of confusion. People can develop blurry vision, and they're peeing a lot because when their blood sugars are high, we urinate out more sugar, and that brings with it water. So we pee more, and then you need to quench the thirst, and so people are drinking more. So those are some of the major symptoms of elevated blood sugar, but for the vast majority of the time, it's really on a screening blood test that we figure it out.
I think this will be one of our last. What is a successful sort of psychology or approach to living with type 2 diabetes and not feeling like we've failed somehow? I think, Lauren, you spoke to the shame and the blame and the stigma that people might be feeling. Any tips or coping recommendations?
From my perspective, I think that going into the mindset that this is something that's handled over a long period of time, so it's a accumulation of so many different choices and so many different small acts that when one doesn't go so well, when one result is higher for your blood sugar, or when one meal isn't the perfectly balanced plate, understanding that it's not a sprint, it's a marathon can really go far, I think, in helping put in perspective how those different things might affect your diabetes and hopefully give you the mindset of, okay, so this thing didn't go so well anymore. How do I funnel my energy not into, feeling like I'm a failure or feeling lots of shame, and how can I push that into planning for next time? Because we know that because it's not an acute phase, it's not a short-term thing that we're managing, being really well prepared for the next time you might be in this specific context or set of circumstances. So if this is your first holiday managing diabetes and it doesn't go 100% perfectly, how can we think ahead to next year rather than, I do hear a lot of really negative self-talk, and people don't even realize they're doing it when we're sitting having a conversation about how things are going with their diabetes management. People say, I'm really bad at this. I eat all this terrible food. I'm the worst when it comes to candy. And they don't even notice it until I point it out to them and say, hey, you're like really hard on yourself, hey? How would you like it if someone spoke to your kid that way, or your spouse that way, or even spoke to you that way? And a lot of the time the answer is, well, I wouldn't put up with it. And my response to that is always, well, how can we take that obviously the motivation is there, the want to make change, and put that into something that is going to have more of a positive and beneficial outcome rather than just beating ourselves up over it. I had something to add.
Okay, any last closing comments?
Just one thing, and that is that the future actually looks quite bright for diabetes. So we talked a bit about semaglutide, but there's super semaglutide on the horizon. So there actually will be medications that are even better at controlling diabetes and also helping people who need to lose weight have success. So yeah, the future looks really bright for people who are living with diabetes. Oh, so the question is, what's the importance of hydration?
In general, hydration is super important for everyone, and the older you are, actually, the higher your fluid requirements are. So oftentimes we think, like, because of those ingrained habits and behaviors, habits that may have served us 10 or 15 years ago, especially, with the results of climate change, as summers get really hot and we're getting those longer stretches of really hot weather in the summer, but even in the winter too, or when the weather is like how it is today, hydration is super important. I think that's great. And just for overall, it doesn't matter if you're managing diabetes or not managing diabetes, really important, because once you're feeling that thirst, you're actually beyond the signs of dehydration. So checking in with your body often, carrying a water bottle or keeping something at elbow length, I think is always a good plan. I know some people in the past stick sticky notes on their fridge that just say, hey, you drink 2 liters today. And that's like the visual reminder that interrupts their habit, their routine enough so that they actually do increase. Or a phone alarm can be really successful too, or a special mug that you really enjoy. All of those things, I think can really contribute to good hydration.
That's it. That's all today, folks. We have to be timely and respectful of our friends here at the Ravens Cry, and say thank you very much for coming out today. And we really appreciate your support for Sechelt Hospital Foundation. And thank you, speakers, for all of your time and really terrific insights. And thank you, Joanna, always for hosting.